This presentation will cover pharmacological considerations in pregnancy and breastfeeding. So the first half of this presentation will discuss pregnancy and the second half will be breastfeeding. So for pregnancy, we'll talk about some of the pharmacokinetics and how pregnancy can impact how drugs move through the body. And then we'll talk about placental drug transfer, which leads right into effects of drugs in pregnancy on the fetus. And then we'll go over some of the most common drugs that would be prescribed in pregnancy. Obviously, anytime we're talking about different drug classes in this course, we're thinking about how they can impact or how our drug selection would be impacted by if somebody was pregnant or breastfeeding. But particularly for this lecture, I'll hit some of the most common ones. And then for breastfeeding, we'll go over some of the pharmacokinetic considerations, more so just the physiology behind how medications are getting into the breast milk. And then we'll go over general considerations for drug use in breastfeeding as a prescriber. So for pregnancy, let's think about the pharmacokinetics and how pregnancy would impact how a drug is absorbed, then distributed, then metabolized, and finally eliminated. So for absorption, if a woman is particularly nauseous and vomiting, then the drug might not be absorbed at all, depending on how quick she might have thrown it up. And then, of course, we've got the slow GI motility that happens in pregnancy, meaning that medications would be in her GI tract longer, so the potential for more absorption there. But then there can also be delayed gastric emptying in pregnancy, and that delay can delay the onset that the drug initially takes effect. So it can take a little bit longer before it starts to get absorbed. And then we also need to keep in mind that respiratory volume increases by about 50% in pregnancy. So while GI medications tend to take a little bit longer to get started, medications that are absorbed in the lungs tend to don't need as high of a dose because there's so much extra respiratory volume present to be able to absorb the medication. So if you're giving any kind of an inhaled medication, then you'll probably need a lower dose when a woman's pregnant. So you'd be prescribing a lower dose. So that would be something to keep in mind as far as dosing goes. So then for distribution, we've got body fat stores that are increasing by 6 to 10 pounds or so. And so if you have a lipophilic drug, drugs that really like to rest and concentrate in fat, then those medications might have a prolonged effect simply because there's more fat on board or adipose tissue. And then on the flip side, if you've got a hydrophilic drug, you can see that in pregnancy, plasma volume is expanded by approximately 50%. So just dilutionally, if there's a lot more fluid going through the bloodstream, a hydrophilic drug is going to have a reduced plasma concentration just because there's so much blood on board, and so you may need a higher dose. So having a sense of different drugs' properties can impact how we view dosing. Or if nothing else, it helps you understand why you're dosing it differently. If you see that a recommended dose would be different in pregnancy, these different aspects of what the drug likes alongside with how pregnancy is affecting a woman's physiology can mean a different dosing. And then as far as protein binding, we've got decreased plasma albumin. Now it's really not that we have less albumin in our bloodstream so much as the ratio of plasma is so much higher to all the other stuff that's in the blood that it's kind of like a dilutional decrease in plasma albumin. So if you've got a drug that particularly likes to bind to protein, it will probably have more of a pharmacologic activity while it's in a pregnant woman's body because in a sense there's not as much protein for it to bind to, so then there's more drug that's free, not protein bound, that can then act on the body. All right. And then fetal albumin increases throughout pregnancy, and it's about 20% higher than maternal concentrations at term. So that would mean that if you're providing a drug that's highly bound to albumin, that can concentrate in the fetus at term. So again, that effect increases more and more as pregnancy develops. Okay, so we've got absorption and then distribution, how the drug's moving throughout the body. And then for metabolism, I just wanted to note that estrogen and progesterone both affect many different liver enzymes. So for some liver enzymes, it inhibits them altogether, and thus the drug can continue to build up and not be broken down. And then for other enzymes, it really increases their effect. So for example, caffeine metabolism is slowed, so it stays in their system longer, whereas Zoloft is broken down faster. So that'll vary slightly from medication to medication, but it's just good to have an overall awareness that pregnancy is affecting how we would usually think of dosing these medications. And then finally, for elimination, glomerular filtration increases by 50% in pregnancy, so we've got really effective kidneys, so there's more rapid clearance of most all drugs that are eliminated renally. So if there's a lot more going through the kidneys, which most pregnant women can attest to, then you'll see those medications clearing from women's systems more quickly. So moving on then here to placental drug transfer, we're thinking about what properties of a medication make it more likely to cross the placenta. So definitely medications are mostly transferring across the placenta via passive transport rather than active transport. And then within passive transport, it's primarily through simple diffusion. It just floats right on over versus facilitated diffusion. So with both facilitated diffusion as well as an active transport, if the medication appears a lot like an endogenous hormone or compound, then it's more likely to be able to get across because it can use those same pathways that the endogenous hormones would use. Certainly smaller size medications or lower molecular weight would be easier to get across. So heavier they may transfer, but it would transfer more incompletely. So heparin and insulin are both good examples of that, where they're both pretty big, so it's hard for them to cross over, making both of them nice drugs of choice for what those would treat, heparin and insulin. They're too big to get over easily. And then if it's lipid soluble, it's more likely to transfer. And then low plasma protein binding. So if you have a medication that particularly likes to bind to protein or albumin in the blood, then there's just not very much that's free and floating to be able to go through the bloodstream and cross over to the placenta. So if it's stuck to albumin's not really wandering over. So if that makes sense. Okay, and then the more acidic it is, comparatively, the fetus is more acidic than the mom. So medications that are more acidic, have more acidic properties, are more likely to transfer as well. So effects of drugs in pregnancy. Birth defects are detected in about 3% of all births. So when we have this discussion, we need to think about, what would be expected as a baseline. Drugs account for about 2 to 3% of these 3%. So it's definitely nowhere near the majority. Certainly family history, past history, environmental exposure, there's a lot of different pieces to the puzzle of how birth defects form. But it's important to realize that on the whole, drugs are accounting for very few of these. So when we think about timing in the pregnancy for when fetuses are most vulnerable, this is a little bit of a repeat from reproductive physiology. But remember that before implantation, it really is an all or nothing effect. So if the zygote is exposed to something that's teratogenic, if it damages maybe just a couple cells, then it's not really going to affect it too much, and you probably won't notice anything in the long run. But if it affects too many of them, then it's just going to be too much for that pregnancy to continue. And then after we're well established as far as implantation goes, that week 4 to week 10, and I'm not speaking from conception, I'm speaking from the last menstrual period, that would be the most critical period. So if there is an exposure to a teratogen in that time, that's when you see major congenital anomalies. And after you get past about 10 weeks, that's when, if you do have an exposure to something, it would be more minor anomalies or functional defects. So when we're thinking about medications that potentially can cause harm, it's helpful to realize that this 4 to 10 week period is really our most critical period. And certainly there's nuances with some medications that tend to cause more issues towards the end of pregnancy. But when we're talking about birth defects and developmental defects, these are the ones that, this is the time period of greatest risk. And then it's important to realize that anytime we're deciding if a drug would be appropriate for a mother, we have to balance the risk of the medication versus the risk of not treating the disease. And sometimes not treating the disease is going to cause a lot more issues for the fetus in the long run than the potential risk of the medication. So it's never that one side has risk and the other side doesn't. That's important to consider as well. All right, and then I'm just bringing back this chart to remind us. This is weeks gestation. So you can see here everything in red would be the particularly vulnerable period for that body system. So you can see that the central nervous system, it really stretches all the way through that 15-week mark and maybe a little bit beyond as far as when it's most vulnerable. Whereas the heart up through 5 weeks is when the major congenital anomalies would occur, versus the yellow represents more minor defects. And then arms, eyes, legs, teeth, palate, external genitalia, and ears. So we see here this is about our week 4 to about our week 10 is when most of the red can be found. Which unfortunately a lot of our moms haven't even quite figured out that they're pregnant when they're already in that zone. So it's not uncommon for women to have taken something that is a known teratogen in this earlier period of time, simply because they didn't know they were pregnant yet. So let's talk about FDA pregnancy categories. These were first developed in 1979, and we'll go through them, and then we'll talk about how it somewhat oversimplifies the complexity of the issue with trying to decide how to label medications as safe or unsafe in pregnancy. And then on the next slide, we'll talk about how we've actually recently done away with the FDA pregnancy system, and we're doing things differently, and that's as of 2015, so that's really fresh. So technically, everything we're about to go over is out, but I don't think it's far enough out that it isn't important that you have a good understanding of what it is, as well as why it's out, because a lot of parents get confused about it too. And to a certain extent, you may still speak this language in the clinic setting, and it can be helpful for parents to a certain extent. So let's start by just going through each category and talking about basically what is it saying. So for category A, and you'll see that A through X, A implies safer, X implies unsafe. So for A, it means that we've had adequate, well-controlled studies in pregnant women that have not shown an increased risk of fetal abnormalities in any trimester of pregnancy. Now for category B, it could mean that animal studies have shown no evidence of harm to the fetus. However, there are no adequate and well-controlled studies in pregnant women. So it could mean we have animal studies that say they're fine. Pregnant women, we don't have studies. Or it could be that animal studies have shown an adverse effect, but adequate and well-controlled studies in pregnant women have failed to demonstrate a risk to the fetus in any trimester, which are fairly different. So that would be category B. So it could mean that we don't have any studies in pregnant women. That would be the first one, versus, well, the animal studies don't necessarily look great. It looks like the studies that have actually been done in pregnant women show that it should be fine. So fairly different. And then we move on to category C, which gets even more ambiguous. So this could be that animal studies have shown an adverse effect, but there really aren't any good studies in pregnant women. And then versus no animal studies have been conducted and no adequate studies have been done in pregnant women. So category C tends to kind of be the catch-all for we just don't know that much about it, to say kind of one way or the other, really. And then for category D, it's that we've got adequate studies in pregnant women that have demonstrated a risk. However, benefits might outweigh the risks. Versus we've got adequate studies that have demonstrated risk, and that the risk really isn't ever going to outweigh the possible benefit. So when we think about this in terms of what are some of the concerns for using the FDA pregnancy categories here, we see that A through C is basically showing a progression of low risk to higher risk, with B and C both being a little bit on the ambiguous side for really being able to compare apples to apples, oranges to oranges, okay? But D and X really aren't about this being riskier than this. It's really about is risk outweighing benefit. You could have a category D drug that's even more dangerous than a category X drug, but if there's nothing else that can treat this condition, or this condition really needs to be treated, then you might still choose to do a D. So I think about anti-epileptic medications. If a woman seizes, that's not good for the baby either, and depending on what's going on with her medical history and present history, she may need to take that drug. And if there's no other option, then she might take a category D drug in pregnancy. Whereas a category X medication, it might not even be that it causes all that much harm, but there might be a lot of other medications you can take that are perfectly safe, in which case, why would we ever even touch that medication if we've got other better medications that could treat the same condition without any risk? So there would be no benefit to taking this one, given that there are risks. So, and that it's not as though that every time it's going to be that way, but just to understand that D and X, it's not necessarily about how harmful it could be for the fetus. It's about that weighing benefits and risks and what other options are there for treatment. So then swinging back up to the top here, adequate, well-controlled studies in pregnant women have not shown an increased risk of fetal abnormalities. This is our category A. So 0.7 medications can fall into this category. And it's hard because it's a little bit ethically questionable if we can even do randomized controlled trials on pregnant women if we're not really sure what the outcome's going to be as far as the medication goes. Running safety trials in pregnancy is not easy. So even just the fact that we've got these trials, there can be some publication bias to that too. If you do find negative outcomes, are those the ones that are getting published? Who funded those? So on the one hand, there's just very few studies that have been done that are really solid studies. And on the other hand, are we really seeing the studies that have been done that show negative outcomes? So in general, if something's an A, you can basically trust it, but it's not necessarily that black and white. And then something to think about for B is the rigor of some human studies versus no human studies isn't equal, which I've already alluded to. And then with C ranging from really just no studies on anything at all, or inadequate studies, ranging to animal studies show that there might be something harmful, but we don't have anything in women. It's just a really broad range and just a lot of unknowns. Just because there haven't been any studies about it doesn't mean that it's not perfectly safe. Anytime a new guideline starts to incorporate pregnant women, we start out with no research, and then slowly the research starts to come in. I think about that with the Tdap vaccine that began to be recommended for pregnant women. I think it was 2012 now. Initially, it had to be a C. Actually, I think it is still a C. But until that research can come in, we can't definitively say one way or the other. So just a really broad range, and for anything here, it doesn't mean that it's not just as safe as an A, we just don't have the research to show it. And then in the same way, it could be an X, and we just don't have the research to show it. So on the whole, the reason why they wanted to move away from this system is because it just oversimplifies the complexity of the issue too much. And you'll go from this country to another country to another country, and every country has a slightly different way that they try to categorize it, and you'll see like B1, B2, B3 from some countries. And so even just as you're gleaning literature from other countries to realize that we vary in our systems for how we determine the safety of medications in pregnancy. So new FDA labeling. So effective in June of 2015 for new products, and then all the other products are slowly being phased over to this system. So we've gone away from using letters, and instead every drug will come with detailed information regarding its safety profile in pregnancy, which includes labor and delivery, lactation, and then for men and women that are potentially looking to conceive, what their reproductive potential and risks would be for them. So rather than trying to label it with a straight up letter, we're actually fleshing out what the research shows for each individual drug, which takes more time for counseling, but would be more accurate counseling and holds us to a higher standard as prescribers for how we would approach what would be appropriate and what wouldn't be appropriate for us to prescribe. So this was initially proposed in 2008, and it took us until 2015 to get it going. Okay, so let's look over some of the most common drugs that we see in pregnancy to just kind of have an idea of, generally speaking, what do we consider safe in each area. So for vitamins, there's strong research to support that the lack of folic acid, iron, and iodine can cause issues for developing fetuses. So for folic acid, the recommendation is that they start supplementation 3 months prior to getting pregnant and for 2 months into pregnancy, and that results in a 50% reduction in neural tube defects. So very strong research to support that. And then for iron, it's a little bit mixed. CDC recommends that iron be given to women routinely, whereas a lot of other organizations say we really would need to only give it if they're anemic. So giving it routinely doesn't change any outcomes for the mom or the baby, unless, of course, the mom's anemic. So then that wouldn't be routine. But if she's not anemic and her hemoglobin looks fine, then giving iron can cause some GI distress, and if you don't have any clear benefit, then that might be something that you could consider taking off the table. And then for iodine, we know that the lack of iodine can cause severe intellectual impairment issues in newborns, and then it's uncommon for us to see this as being an issue with iodine deficiency simply because we've got iodinized salt, so having it in table salt is really protective. Prenatal vitamins typically have less than the required amount by the American Thyroid Association, but even that said, it tends to be fine, given that we've got a fair bit of it in our diet. All right, so then what might we also consider recommending? So B12, if women are vegetarians, then there is strong evidence to show that B12 supplementation is helpful and protective for babies. And then omega-3 fatty acids, the jury's not completely out about it yet, but there's a fair bit of research showing that it looks like it helps with newborns sleeping better in the initial postpartum period and improve fetal growth, neonatal cognition, improve visual function, preventing postpartum depression in moms. So while it's not super definitive, there's so many potential positives that that's something that you could definitely consider recommending. And then vitamin D, basically that's going to depend on where you live. So here in Minnesota, most of our moms are pretty low. Giving it routinely is not a bad idea. If you have a practice in Texas, that might look very different. So knowing your area is important for that one. And then vitamin A, the max is about 5,000 IUs a day. So it's important, like if moms are low in iron, some of them think, oh, I'll just double up on my prenatal vitamins every day. But you got to be careful because they could end up getting too much vitamin A. So typically their prenatals have at least 800 in it, but that's just something to be aware of as well. And then for antimicrobials, obviously you've already had a lot of in-depth understanding on these, but just a brief overview of what's most common. If it would be appropriate to treat it, we've got the most research around penicillins and erythromycin. So those tend to be the go-to first lines in pregnancy, assuming that it would be appropriate for what you're treating. And cephalosporins are a very close second as far as having a decent amount of research behind them as well, showing their safety in pregnancy. Metronidazole, we haven't ever seen any teratogenic effects from them. A lot of clinicians are a little bit more hesitant to prescribe it in the first trimester, but formally we don't have any need to be hesitant about it. So if they have trichomoniasis, we should be giving them metronidazole. If they have BV but don't have any complaints and didn't know they had BV, well, maybe that's something you could wait till the second trimester if you're more comfortable with that. Just in general, first trimester, we tend to back off unless we really need something. But again, we don't formally have a reason to feel that way for metronidazole. And then sulfonamides, generally speaking, are fine in pregnancy as well. You might see that for Bactrim for UTI. Would probably be the most common place you would see a sulfonamide in common primary care. But it's important to realize that we want to avoid it in the third trimester because it can displace bilirubin from binding sites on protein. So if they're displaced from the protein site, then bilirubin would build up. So in a newborn, when newborns are initially breaking down all their fetal hemoglobin, they need to be able to attach it and get it out. And if it keeps getting displaced, then the bilirubin's building up and they can have issues with jaundice, and kernicterus is more easily developed. So third trimester, i.e. we're close to the birth, when it would matter how that translates after the birth, we want to avoid those. So that's a basic mini window into antimicrobials, which obviously could be a lot longer. Okay, analgesics. So we're remembering acetaminophen is our drug of choice for minor pain during pregnancy. So with NSAIDs, there's a potential risk for the ductus arteriosus prematurely closing because it's prostaglandins that help keep it open. And then also there's concern about if you're taking NSAIDs, that could disrupt the prostaglandin cascade that's needed for labor initiation. So if people are taking NSAIDs, they're more likely to go post-term, which actually in the past has been a potential treatment for those that are having issues with preterm labor, interestingly enough, but we have to be aware of the ductus arteriosus concern as well. And then for opiates, we'll see avoiding those because we don't want the newborn to become addicted and have concerns about withdrawal or dependence after the birth, but there are no teratogenic effects associated with opiates. So just so we're distinguishing between that and understanding what our goals are there. And then with anti-epileptics, I won't get into these in great deal, but just to know that the newer generation of anti-epileptic drugs doesn't appear to have any teratogenic effects. So that's like Lamictal and Neurontin, for example. Versus the older drugs, it's a long laundry list, which I will let you learn about as these issues come up in the rest of the course. So phenytoin, valproate, valproic acid, some of the older anti-epileptics have historically had a lot of issues. And then for antidepressants, it's important to realize that there's definite risk if it's not treated, as is true with epilepsy. But preterm birth, postpartum depression, poor behavioral and mental health outcomes in children. So as providers, we recommend treating depression. Now, whether you feel confident in diagnosing and managing that, a lot of times they'll end up being referred out. But ensuring that it truly is depression, that we, if that's the case, then we should be treating it. And for the most part, SSRIs are generally okay. We do have some concerns regarding neonatal withdrawal, particularly based on their dose in the third trimester. But still, in terms of thinking about risks outweighing, or benefits outweighing risks, we want to be treating, and we don't want to be lowering people's dose right before they're giving birth and having that postpartum change, and especially if we've already got a medication on board that's working. If that particular one is essentially safe, then we'll stay with it. And especially when you first graduate, you're probably going to need to look up every single drug that you're prescribing until you get comfortable with a little handful and you remember that this is something where we're continually going back and looking at that specific drug. So in general, we say Prozac is your best one for pregnancy, and Zoloft would be your best SSRI for postpartum while women are breastfeeding. But either of those would be fine in both settings. And really the only one that we're definitely wanting to avoid is Paxil. Paxil is associated with an increased risk in cardiac anomalies. It's a 1.5 to 2 times the risk. So with the exception of Paxil, you can generally go to an SSRI. And again, look it up before you prescribe it. Alright, so hypothyroidism, again, if it's untreated, it can lead to fetal mental retardation, preeclampsia, stillbirth, so we're wanting to treat it. I just gave a little sampling there, that list could be longer. So levothyroxine or Synthroid, it's important to realize that you might need to increase your dose when she becomes pregnant based on how the body's processing it, as well as what a woman's thyroid needs are when she's pregnant. So that increase may be even up to 25%. A good rule of thumb is if she's already been on a certain dose of Synthroid, when she gets pregnant, to just plan to bump it up at least 25%. And then anytime you're changing somebody's dose, you will recheck their TSH and T4 4 to 6 weeks or so after you've changed the dose, and then that's when you would expect to see a consistent, steady state and can see what the change you've made is doing, and then you can alter it from there. But assuming that everything looks great and her labs are fine, then you should check in on her labs at least once every trimester. And we don't have any adverse outcomes associated with levothyroxine. And again, no risks on that side, whereas the risks of not treating are high. So I think explaining that to parents, especially if there's a specific concern with whatever the condition is that they're needing treated, a lot of moms want to toughen it out. And if we can really explain that, there's always a potential risk associated with taking or eating anything in pregnancy, but if there's a known risk on the other end, and especially if that known risk is fairly significant, then it would be in our favor to treat. And then for antihypertensives, a lot of them have big issues, but your first line is going to be beta blockers, which comes in handy since that is a very popular antihypertensive even if you're not pregnant. With the exception of atenolol. Atenolol's got documented issues, but the rest of them seem to be fine. And labetalol is definitely your go-to and the most popular one you're going to see. One other one, though, that you could use would be nifedipine. The calcium channel blockers also appear to be safe. So you'll also see nifedipine used on labor and delivery. It can be used as a tocolytic, too, so it can slow down contractions. Or even potentially stop them, depending on what's going on. Alright, so common drugs in pregnancy continued. Anticoagulants, just know that heparin's your drug of choice. It has a hard time crossing over the placenta, again, because it's so big, like I mentioned earlier. And Coumadin just comes with a laundry list of issues that it can cause, and it has no trouble crossing. So heparin would be your go-to in pregnancy if they needed an anticoagulant. And then hypoglycemic agents for diabetes. Basically, if somebody has diabetes going into pregnancy, we would treat them the same as we would treat somebody who has gestational diabetes in terms of diet, exercise, and insulin essentially being the core of what we're recommending. Insulin, again, is large. It has a hard time crossing over the placenta. So that's in our favor as well. There's also been a fair bit of research that's come out around glyburide and metformin that's showing a lot of promise. So both of those appear to be safe as far as oral agents, but they're not necessarily fully endorsed yet by our top organizations. But know that is up and coming and becoming more of a possibility, and you may have already seen it in practice as well. Partially because glyburide is very protein bound, so it doesn't want to let go and cross over to the placenta because it's happy just being on albumin. Okay, so let's look at drug use in breastfeeding. So, brief overview of our physiology. From our hypothalamus, we're getting a message here for prolactin through the anterior pituitary, and then oxytocin is released from the posterior pituitary. So prolactin makes the milk, and oxytocin is our milk ejection reflex. And then we can come over here to see our alveoli, and then we can call these our alveolar cells, or our lactocytes. And as more and more milk forms here, it's flattening out these alveolar cells, which is sending the message to our brain that we can slow down on milk production, but then as milk drains out, then that sends the opposite message. So just as kind of a reminder for how that works. Okay, so let's think about some considerations with the physiology as it relates to breastfeeding and drugs. So with most drugs, it's going to be less than 1% of maternal plasma level of the drug that actually crosses into the breast milk. So for the most part, it's pretty tight junctions between each of these alveolar cells. You can see these are our alveolar cells, and then these are blood vessels that wrap around the alveolar cells. So if there's quite a few gaps in between these alveolar cells, then more is going to absorb out of the bloodstream and into this open space here where the milk is collecting. So for the first few weeks of life, however, there's a large gap between these alveolar cells. So whatever a mom's taking in the first few weeks of life, that's going to get over to baby quite a bit more easily, which helps for mom being able to pass over extra immunoglobulins for baby's immunity. So that has a protective effect, but we should just be aware any medications mom's taking initially postpartum have a greater likelihood of passing, or a higher amount of it is going to pass over to the baby. So let's see here. Okay, so primarily it's passive diffusion through the alveolar cells. That's how medications would cross. So it's fairly easy transport. Obviously that's not the only way, but primarily that's how everything's moving. Majority of the milk is produced at the time of the feeding. So that's important for moms to understand. You'll remember the majority of the feed her baby's getting is what's currently in her bloodstream. So if she's going to take any medication, really, taking it right after a feed or right before baby's going to have a long stretch of sleep, that will mean that by the time she feeds again or nurses again, there'll be less of it in her bloodstream, and less of it will ultimately pass over to her baby. So that's important for all our moms to understand. And then lastly, I just wanted to explain this concept that holds a little bit of value. So it's the milk plasma ratio. So basically what that means, it's up to 1, and it means that the milk plasma ratio, like if it was 0.1, that would mean that breast milk is containing 10% of what's in the maternal blood plasma. So, and again, if it's 0.5, then baby's getting half of whatever mom's getting, or I don't know if I said that right. If what's in mom's bloodstream is 100%, this is saying, well, what percent of that ends up getting over to baby? So it doesn't really speak to safety at all. It's only really speaking to how much of it's easily transferring. So it can be a really high amount that's transferring, and it can be perfectly safe. If it's a medication that a baby would be fine to take anyway. Or it could be that it's a very low amount that's transferring, but it's very unsafe to be taking when you're breastfeeding. So it doesn't speak to safety, but it is still a helpful concept to understand. For example, say it is unsafe, and even though it's in a low amount, that could be concerning. If, say, the drug clearance is really slow in the neonate, or the half-life is unusually long, that kind of thing, then that can potentially be a greater issue if you've got a milk plasma ratio that's higher. All right, so it's difficult to make recommendations in regards to drug use in pregnancy. Many drugs are excreted in breast milk. Again, it's nothing compared to the serum levels you've got in mom, but a lot of them are going to pass over. And honestly, ultimately, it comes down to you using your references on a case-by-case basis and looking it up. Older medications tend to be preferred simply because we've got more data on it. AAP lists the following medications as contraindicated, so I'll let you look over those. Whereas AAP says that these other ones are fairly safe. So antibiotics in general tend to be safe. Analgesics in general tend to be safe. So take a look at those. All right. So then let's also be aware whether it's safe or not safe. Let's think about what could actually affect milk supply. So sometimes our recommendations around breastfeeding aren't related to so much the safety of the baby, so much as her milk supply. So drugs that can decrease milk supply, anticholinergics, androgens, estrogen. Again, that's why we're just doing progestin-only pills or progestin-only methods if women are wanting a hormonal form of birth control while they're breastfeeding. Or at least wait till that milk supply is really well established. And if you've had any concerns around that, then stay away from it. So you can see kind of what's on the list there. And Sudafed, I'll actually see women with an oversupply, which can actually be really life-altering for some women. Taking Sudafed, I've seen them take Sudafed in hopes that it will decrease their milk supply. And certainly you can bring foods and herbs and things into this mix as well. Oregano and sage are also ones that I see women taking to see if it can help decrease their milk supply. Oregano tea, doesn't that sound good? All right, and then we've got drugs that can help to increase milk supply as well. I don't know that we say we're doing it to help it so much as they might notice that. So there's some drugs there. And then metoclopramide or Reglan is one that's been of particular interest. And it's not FDA approved for the purpose of an increasing milk supply, but that's one of the side effects of the medication is galactorrhea. So sometimes you'll see practitioners give maybe like a 10-day course of taking metoclopramide, and then that boosts a woman's milk supply, and then she's done, and that can help her from there, which I've seen that be successful, and then I've also seen it tip off once the 10-day course is done. But it crosses the blood-brain barrier, and there's a few different side effects that can be a little bit concerning with Reglan, especially given that it's not FDA approved. I added domperidone on here. It's not FDA approved in the U.S. It's used a lot in Canada. It works basically the same as metoclopramide, but it doesn't cross the blood-brain barrier, so a lot of the potential side effect concerns we see with metoclopramide don't exist for domperidone, but you can't get it very easily in the U.S. So if that was something you wanted to explore, I like it, and I have used it a handful of times with a lot of success for moms. But you'd have to call it into a compounding pharmacy, or she could order it like online from another country, which sounds a little bit ridiculous, but I cannot even tell you how many women I've seen do it. I don't recommend that they do it. I think that's really hard to know, how accurate is your dosing for everything. And even with a compounding pharmacy, it's not like it's carefully looked at from the FDA, for example. But for example, I had one mom not that long ago who had a breast reduction and then later got pregnant, and then her baby ended up needing to be in the NICU for a week or two after the birth. So breastfeeding got off to a rough start, and she was maybe able to get, I can't remember how many ounces, but it was probably about 25% her milk, 75% formula, when she was going home and established. And And through taking domperidone, it got to the point where she was able to get up to be about 75% her and 25% formula, which she was really happy about, and that felt like that was a good place for her. And initially, she didn't think that that would be possible. She thought that it was the breast reduction was going to ultimately impact her ability to be primarily breastfeeding her newborn. So it can be a good option. And it's worth doing some more research before you jump on the bandwagon yourself. All right, so last tips here from the AAP regarding breastfeeding and medication use. So first, use drugs only when necessary, especially in the first couple weeks. Second, use the smallest therapeutic dose for the shortest time that is effective. I'd hope in general we do that for everything, but especially for this, that makes sense. Use drugs with shorter half-lives. That way, by the time they're nursing again, there's just less of it in their system. So that's kind of helpful. I think for any given category of medication, if there's not that much distinguishing research from one drug to the next within a category, then just pick the one with the shortest half-life and go from there. Arrange the timing of drug dosing so that it's given immediately after nursing or before the infants have a long sleep period. We talked about that. If the drug is contraindicated for infant exposure, pumping and discarding may be necessary. So keep that as an option. If it really is found to be unsafe, it doesn't mean we have to stop breastfeeding. But if she needs to take something for a short course, that would make sense. And the same is also true if a drug is often used for infants, then you can basically know that it would be fine for her to be breastfeeding and using it if it's considered a safe medication to give straight to babies. And then lastly, it's very rare that a medication is a reason to discontinue breastfeeding. So in the spirit of all of this, let's make sure that we're keeping breastfeeding going strong, and that having a UTI. I mean, I just think of so many moms that come in and weren't given any extra education around their medications, so they assume that they can't be breastfeeding while doing it. So they get a UTI, they get a course of antibiotics, they stop breastfeeding, they go to start when it's done, and then their milk supply is significantly down. So let's really be dedicated to making sure that we're helping moms get over the hump of medications with still breastfeeding strongly. And usually it's fine to be breastfeeding. So look up your medications as you go to be safe. So for resources for pregnancy, the FDA is great. And then I gave you another couple sources that are really helpful for looking at medications. And then breastfeeding, I'm a huge fan of BlackMed. You just put in the drug and it tells you everything we know thus far. It's like a sub-branch of PubMed. All right, so that's everything that I've got. And if you guys have any questions, feel free to add a question to the general forum. Okay, hope you guys have a good week.